Hello, I am Dr. Khalilah Jefferson, DNP. Today, I want to discuss the diagnosis you don't get confronting bias in healthcare. Imagine this: you walk into a hospital in pain. You explain your symptoms clearly. You wait. You're told it's probably stress. You go home, and later you find out it was a heart attack. This is not hypothetical. Research from institutions like Harvard Medical School and reports from the Centers for Disease Control and Prevention show that certain groups of people are systematically less likely to be believed, properly diagnosed, or adequately treated. This is not about bad doctors. It is about biased systems, and every one of us is affected. What is bias in healthcare? Bias in healthcare is not always loud or intentional. Often it's subtle. It's assumptions about pain tolerance, compliance, lifestyle, intelligence, or risk. Sometimes it is built into algorithms. Sometimes it is in medical textbooks. Sometimes it is in us. And when bias enters the exam room, it changes outcomes. Who is affected the most? Let's talk about who pays the highest price. One, women. Women are more likely to have their pain dismissed as anxiety. They are less likely to receive pain medication in emergency rooms. Heart disease, the leading cause of death for women, is underdiagnosed because symptoms don't always look like the classic male presentation. For decades, clinical research centered primarily on male bodies. Female biology was treated as a variation, not the standard. The result: women are more likely to be misdiagnosed, especially women of color. 2. Racial and ethnic minorities. Black patients in the United States are less likely to receive adequate pain treatment compared to white patients. A shocking study found that some medical trainees believe false biological myths, such as the idea that Black people have thicker skin or feel less pain. These myths trace back to slavery era pseudoscience, and echoes of them remain. According to the American Medical Association, structural racism continues to influence access to care, maternal mortality, and chronic disease outcomes. Black women are significantly more likely to die from pregnancy related complications than white women, regardless of income or education. Think about that. Even when controlling for wealth and access, bias persists. 3. People with larger bodies. Patients in larger bodies often report that doctors attribute nearly every complaint to weight. Broken ankle, lose weight. Migraines, lose weight. Black women are significantly more likely to die from pregnancy related complications than white women, regardless of income or education. Depression, lose weight. Weight bias leads to delayed diagnoses for cancer, autoimmune diseases, and hormonal disorders because symptoms are dismissed instead of investigated. Shame becomes a substitute for science. 4. LGBTQ plus individuals. Members of the LGBTQ plus community frequently delay medical care due to fear of discrimination. Transgender patients, in particular, report being refused treatment unrelated to gender identity. When people avoid preventive care because they don't feel safe, small health problems become big ones. 5. People with disabilities. Individuals with physical or intellectual disabilities often experience diagnostic overshadowing, where symptoms are attributed to their disability instead of investigated properly. Pain becomes behavior. Fatigue becomes a baseline. Warning signs are ignored. The cost of bias. Bias doesn't just hurt feelings, it shortens lives. It increases maternal mortality. It delays cancer detection. It worsens chronic disease. It deepens mental health crises. And it erodes trust. When communities don't trust the healthcare system, they delay seeking care. And delay turns treatable conditions into tragedies. How did we get here? Healthcare systems were built within societies shaped by inequality. Medical research historically excluded women. Insurance systems tied access to employment. Bias didn't accidentally slip in, it was baked in. But here's the hopeful part: systems can be rebuilt. What can be done? Diversify the healthcare workforce, Patients often experience better outcomes when treated by providers who understand their lived experiences. Reform medical education. Schools like Johns Hopkins School of Medicine and others are integrating structural competency and implicit bias training into curricula. Change clinical research standards. Clinical trials must include women, racial minorities, older adults, and people with disabilities. Audit healthcare algorithms. Some medical algorithms have underestimated risk in Black patients by using cost as a proxy for health. Technology must be examined, not assumed neutral. Listen, the simplest intervention is sometimes the most radical. Believe patients. Why this matters to everyone. You might think this doesn't affect me, but bias is not static, it shifts with context. Age bias affects older adults. Mental health stigma affects millions. Language barriers affect immigrants. Socioeconomic bias affects the uninsured. At some point in your life, you or someone you love will sit on that exam table. And in that moment, you will want to be seen fully, accurately, without assumption. A new vision of care. Imagine a healthcare system where data reflects all bodies, pain is believed, cultural humility is standard practice, and access is not determined by zip code. This is not idealistic, it is achievable, but it requires acknowledging something uncomfortable. Bias exists even in spaces dedicated to healing. And once we see it, we cannot unsee it. The next time you or someone you know walks into a clinic, remember healthcare is not just about medicine, it's about humanity. And the most powerful diagnostic tool we have is not a machine, it's empathy. Thank you.